Okay, we did traumatic brain injury. Um, Terry is a 40-year-old female who sustained an open traumatic brain injury 4 weeks ago. She was in a coma for the first 2 weeks and is now in a rehabilitation setting. Her RLAS score is 4. She has a max assist for gait, mod to max assist for supine to sit, general bed mobility activities, and squat pivot transfers. Generalized weakness of 3- out of 5 throughout extremities and trunk, mild to moderate velocity dependent hypertonicity, coordination difficulties during eating, dressing, and for various mobility activities. Terry gets frustrated with nurses when they are trying to perform rehab. The staff gets frustrated with Terry and states that they have shown her how to eat, but she just doesn't get it. She is really slow at everything. Terry's current state makes her unable to be independent in all environments. She's confused, agitated, and requires mod to max assist in all areas of ADLs, I8, and IADLs. TBI-related hospitalizations in 2018 were approximately 223,050 or 610 per day. In 2019, it was reported that there were 61,000 TBI-related deaths in the U.S., or about 166 deaths a day. Males are 2 times more likely to be hospitalized from TBI and 3 times more likely to die from it. Patients 75 years or older had the highest numbers and rates of TBI hospitalizations and deaths, mostly due to falls. TBI affects how the brain works because of an injury to the head caused by an external physical force. The main causes are car accidents, gunshot wounds to the head, or falls. The brain consists of 3 to 4 pounds of soft tissue floating in fluid within the skull. It can be stretched, pulled, and compressed. During an event, such as a car crash, the sudden speeding up and slowing down can move the brain around violently inside the skull, causing damage. A person can acquire an open or closed head injury. An open injury is when the skull and its other protective layers are damaged and exposed to air, such as with a gunshot wound to the head. A closed injury is when the skull and brain contents have not been broken into or penetrated. There are 3 levels of TBI: milder concussion, moderate, and severe. TBI injuries can last a few days, result in long-term complications, or cause death. A mild brain injury includes nausea, vomiting, slurred speech, balance problems, and dizziness. Sensory symptoms include blurred vision, a ringing in the ears, and sensitivity to light and sound. It also includes loss of consciousness for a short period of time, disorientation, memory, and concentration problems due to a deterioration of mental function, and also anxiety. Moderate to severe symptoms include seizures, pupil dilation, loss of coordination, weakness or numbness in hands and fingers, persistent headache, loss of consciousness for several minutes to hours, and increased intracranial pressure. Specific tests for TBI: the Glasgow Coma Scale, the most common scoring system describing the level of consciousness and severity in a person following a traumatic brain injury. It is a summation of scores for oculomotor, verbal, and motor responses, with a minimum score of 3 indicating a brain dead state and a max score of 15 indicating a fully awake patient. The Ashworth scale measures the presence of abnormal muscle tone and spasticity during passive range of motion. The score ranges from 0 to 4, indicating no increase in tone, to affected limb being rigid in flexion or extension, respectively. The Ranchos Los Amigos scale evaluates the TBI patient's cognitive and behavioral patterns. The levels can be reevaluated as the patient's behavior changes and is making progress in becoming more independent. Balance and functional tests include the 6-minute walk test, Berg balance test, synergy tests, kinesthesia, and coordination tests. Surgery may be needed in emergency situations, which can include removing blood clots or pools. These areas of pooling blood can damage brain tissue by putting pressure on the brain. Relieving ICP, or intracranial pressure. The brain can be damaged when increased pressure and swelling occur inside the skull. In these instances, making a hole, adding a drain or shunt may be needed to relieve pressure or release excess fluid. Repairing skull fractures. In order to start the healing process, removing any pieces of skull or debris from the brain after a severe skull fracture is necessary.
Okay, medications. Medications are used to help lower the risk of associated conditions and help treat other symptoms related to recovering from a TBI. These can include diuretics, mannitol, in order to reduce ICP by draining excess fluid. We also have muscle relaxants, baclofen, diazepam, tizanidine to treat muscle spasms. Anticoagulants like warfarin can help improve blood flow and prevent clots. And then anticonvulsants like gabapentin, phenytoin, and valproate sodium for seizure prevention. And antidepressant medications like Zoloft, Celexa, and Paxil as well to help treat emotional disturbances. Side effects of medications could cause issues in a patient's function during therapy. For example, the anticonvulsant gabapentin has the common side effect of dizziness and drowsiness. In some patients, uncoordinated movement has been associated with this drug as well. All of these could cause an issue during therapy with alertness, movements, and the patient's safety. In the acute stage, a TBI patient might not be medically stable due to increased intracranial pressure, ICP. Respiratory needs, you need to look out for like the mechanical ventilation or in moderate to severe TBI, reduced maximal aerobic capacity and resting pulmonary capacity parameters post-injury. For data collection, we have the Ashworth scale to later reevaluate Terry's current mild to moderate hypertonicity. The Rancho's Los Amigos scale evaluates her cognitive and behavioral patterns. The levels can be reevaluated as her behavior changes and is making progress and becoming more independent. The Berg's balance scale evaluates her ability to sit, to stand, and to transfer. Currently, she's mod to max assist in these areas. Expectations. The effects of a moderate to severe TBI may vary from person to person and can change during the recovery process. Most patients will have one or multiple health problems after the recovery. Terry is still in the early stages of recovery, and it might be too soon to tell what her final outcome will be. These are all comparative tests, therefore, the results should show a positive increase on each scale to show improvement or a decrease if the patient is declining in their condition. As for interventions, for therapy, things to be considered are her level of agitation and frustration, her lack of coordination, hypertonicity, and general weakness throughout her extremities and her trunk. The best current interventions would be a range of motion exercises such as passive, active, facilitated, like using PNF techniques, passive stretching through positioning and splinting, mobility training, and manual techniques, re-educating postural stability like rhythmic stabilization or stabilizing reversals. At the later stage, adjusting the complexity of tasks like dual tasking with cognitive or additional physical elements and progressing assistive devices for gait training can be used depending on Terry's progress. For contraindications and precautions, is the patient medically stable at the time of therapy, oriented, able to follow commands? Are there any medication side effects present? For any additional considerations, you can go to the next slide. Yes. Um,
The
the
next one.
patient the patient experienced a coma for 2 weeks before being admitted to a rehabilitation facility. The Rancho's Los Amigos score is 4, meaning she's confused, agitated, and alert. She is shown to have difficulties with her coordination and is frustrated during rehab sessions. The best course of action is to reach out to her mental health counselor to gauge how well she's going to adjust to her situation. This particular case does not give a lot of information on her social situation. She's a 40-year-old female staying in a rehab setting due to a TBI, so we could possibly assume that she doesn't have much family, as the nursing staff has been showing her how to eat and is frustrated with her. There's no mention of family trying to help in any way. In this situation, I'd collaborate with her case manager and her mental health counselor to gather any important information about her home life, finances, and social life. Understanding her situation is a good method in determining the best course of treatment. For example, does she have a family member to assist her after discharge? If she doesn't have anyone at home, we could prescribe a longer period of household ambulation with assistive devices or assign any home health therapists until she is feeling independent. Okay, for therapy progression, we have our short-term goals being to work on coordination. Terry has difficulties eating, dressing, and performing mobility exercises. The second goal, we could also work on her cognition because she is not able to follow directions and may have trouble with her cognition. Any long-term goals include independent with bed mobility and transfers, and the second goal is independence in ambulation because she requires max assist for gait. For progression, TBI recovery requires mass practice, such as high repetition exercises, in order to utilize neuroplasticity for recovery. The more these neural pathways are reinforced, the stronger they become and the easier it gets to perform that function. Exercises include balance and postural control training like weight shift and midline orientation activities when transferring and in sideline or sitting. We also could do core exercises and progression of various postural sets include crook position, bridging, side lying prone, 4-point kneeling, high kneeling, sitting, perching, standing, step stands, prone, standing, and others. Progressing gait with easier to harder types of assistive devices. And as for discharge planning, I've already mentioned before, we don't know what her situation is like. And the last thing you would want to do is to discharge someone to a home where she doesn't have any support. So again, we would have to reach out to other practitioners involved in her case to know for sure. Okay, and these are our references.